Right. Okay, good afternoon, everyone. We might get started. All good. Well, welcome. Welcome to this afternoon session on mental health. I hope you've all been enjoying yourselves this morning throughout the conference. We've heard from some incredible speakers, and I just personally think the next few days are going to be fantastic. Before I continue, I do want to take this moment and this opportunity to acknowledge the traditional custodians of the land on which we meet, the Wiradjuri people, and pay my respects to elders and Aboriginal and Torres Strait Islander people, past, present, and emerging. I do also want to take this moment to give a bit of a mental health disclaimer / trigger warning for all those here and also tuning in from home online. I am going to be talking about mental health, and I think when we are having difficult conversations and discussions, the best way to do it is sometimes to be quite direct. So that means I will be talking about things relating to not only mental health, but trauma, suicide, and addiction. So if at any point anyone feels uncomfortable, please do what you need to do. Take a moment to step outside, call a friend, come and grab me in the break to debrief with me, whatever you DM me on the Hoover app, whatever you need to do, by all means do it, because we're all about keeping people mentally well and mentally safe throughout this. So when Irfan reached out to me a couple of months ago asking me to talk on the topic of mental health, I thought, oh my goodness, where do I start? There's so much to say. We're in the middle of a pandemic. Mental health rates are the highest that they have ever been in history, and suicide rates are on the increase. So we currently, unfortunately, lose approximately 9 people a week to suicide. Not only this, the mental health system at the moment is incredibly burdened and stressed. It makes me shudder to think about how strained our health and mental health care workers and systems are at the moment. So we have this massive problem of rising mental health rates and really limited access to some services at the moment as well because of the strain. And big problem, but here we are at a conference whose catchphrase and slogan is literally, "Are you ready to change the world?" And so I thought, okay, yes, I am. So in thinking about what to talk to you about today, I took a breath, I sat down, I pulled out my Speeches That Changed the World textbook that I have at home, put on a bit of John Lennon, and got to work thinking about what can I possibly do that's going to influence some sort of change today. But while I might not give a speech that changes the world, what I have learned and continue to learn is that change, particularly within mental health, but more broadly, is made up of us taking consistent steps. And sometimes they are small steps. Often they're probably small steps. Sometimes they don't feel like particularly important or meaningful steps, but they are steps nonetheless. And collectively, they add up. I flew in from Sydney last night, and I had an interaction with a gentleman that was a moment for me that said, we have change that's happening within mental health. We're getting there, slowly but surely, we're getting there. So I was at the, if I just tell you the story, I was at the taxi rank getting a taxi from the airport to the hotel. And the gentleman, I'm not sure what his title would be, but he coordinates the people getting into the taxis and the taxi rank. He was standing there was a bunch of us waiting and no taxis. And so we started up a bit of a conversation, and he asked me why I was here. And I mentioned, I'm a psychologist and I'm here for a conference. And often when you tell people you're a psychologist, you get a couple of stock standard responses. One of them is people will kind of like nod and then just like slowly inch away from you, and that's the end of that conversation. You get other people who, the other standard one is like, oh, have I got a person that you need to see? I'll give you the number of my mother-in-law, or something along those lines. But this gentleman, in fact, proceeded to tell me that throughout COVID, he had lost his job, he was unemployed, and at one point had considered suicide. And I did my best to try and validate what he'd said, his experience, the fact that he'd shared that with me. We exchanged a few sentences back and forth. I hopped in the taxi and that was the end of it. But it really got me thinking that potentially 10 years ago, 5 years ago maybe, it wouldn't have been something that this gentleman might have actually shared with me. And furthermore, he was someone who we could say had a number of risk factors. So for one, he was male, and we know that men experience greater levels of stigma and shame than females do. There is research that says that there is more difficulty with them being able to be vulnerable because of the shame that exists. So that was one factor. Second factor, he was an older gentleman. And we know that older people, again, do not necessarily have the mental health literacy that the younger generation do, and are not as open and vulnerable in being able to share about their mental health concerns. And thirdly, and I'm making an assumption here, he was a gentleman with quite a heavy accent. He was quite possibly not born here, so from some sort of culturally and linguistically diverse background. And again, we know that stigma and shame within these communities is particularly strong. So he had 3 risk factors, and I thought, wow, here is someone who has opened up and shared with me. What a moment that I'm going to take away as an instance that we have change that is occurring. We still have a long way to go, but there is change that's slowly but surely happening. So on that note, my name is Dr. Anastasia Hronis. I am a clinical psychologist. I'm the founder of the Australian Institute for Human Wellness, and I'm also a researcher at the University of Technology, Sydney. So essentially, I see people clinically for therapy, one-on-one in groups, and I do some research. And I'm really pleased to be here at this conference today because it is a different kind of conference than what I would usually attend. Many of the conferences I attend have a very strong academic focus where I sit in awe of the professors who are presenting on their research that they've been conducting for years and years. And there's a real strong research academic focus. That said, we know that there is the research practice gap. So I'm not sure if people are familiar with this statistic, but on average, it takes 17 years for research to be translated into practice. So we're 17 years behind at the moment actually implementing into practice what we had research for, 17 years ago. So the conferences that I would attend were usually quite academic focused and also quite specific to either mental health, psychology, or even more specific disorders. So being here today and over the next couple of days is really pleasing for me because I'm in amongst experts and people with lived experience with such knowledge and wisdom pushing for change more broadly and change generally, social justice and social change. And the more I hear from the presentations this morning, the more I realize I don't know. And I'm so glad that I'm here in amongst people who do know. But one thing I have come to realize is that change within mental health cannot exist in isolation. We cannot have effective, long-lasting, meaningful change in mental health unless we are also addressing issues relating to our First Nations people and communities, intergenerational trauma, stolen generations, and closing the gap. We cannot have effective and meaningful change within mental health unless we are addressing issues relating to homelessness. So many of our people who are living on the streets do have significant mental health disorders. We cannot have meaningful, effective change in mental health unless we're also looking at the criminal justice system, rates of incarceration, discrimination, inequalities, raising the age. We cannot have effective change in mental health unless we look at gender inequality, unless we look at making changes within the workplace into workplace mental health strategies, normalizing taking a mental health day, having conversations with our bosses. The number of times that I've had clients attend a session with me and asked me to write a medical certificate for their boss and not put down that I'm a psychologist. We cannot have effective change in mental health unless we address discrimination and racism, and we cannot have effective change and long-lasting, meaningful change in mental health unless we're addressing domestic violence and domestic abuse. and probably a number more areas that I haven't mentioned on this slide, but just some to name a few. So to present you with some statistics that you may have heard, if you've watched the news or digested any sort of social media lately, you've probably heard that we're in some sort of mental health crisis at the moment. So we know that rates of mental health disorders have been on the rise. So currently 1 in 5 Australians aged between the age of 16 to 85 years old experience a mental health disorder or illness at some point in their life. And we know that for the population, about 45% of us will experience a mental health disorder at some point in our life. So almost 50% of us will have a mental health disorder at some point in our life. We know that the most common mental health disorders are anxiety, depression, and substance use disorders, and that these three are often occurring in combination with one another. To put this in the perspective of what it means on a global scale, worldwide, we know that mental, neurological, and substance use disorders account for 10% of the global burden of disease and 9 of the 20 leading causes of years lived with a disability. So a really significant problem for us to be tackling. The National Survey of Mental Health and Wellbeing found that of the mental health disorders that people experience, anxiety being the most prevalent at about 14%, followed by affective disorders or mood-related disorders at 6%, followed by substance use disorders at about 5%. And just that bottom point that I have there, so 16 to 24-year-olds are the most likely to have a symptoms of a mental health disorder. So either a diagnosable mental health disorder or what we would categorize as someone being as at risk in that sort of subclinical range, not quite meeting the threshold, but certainly showing signs that are concerning for us. This is really important. I'll get to talk about this in a little bit more detail, but we really need to be targeting in terms of our models of intervention and stepped care models, young people and early interventions for them. To give you a bit of a snapshot as to how the COVID pandemic has influenced the use of services. So in terms of Medicare services, we know that 11% of the Australian population received Medicare subsidised services in the 2019 to 2020 reporting period. And this was an increase from 6% of 10 years prior. 4.4 million Australians have received a mental health related prescription. And in terms of expenditure, $10.6 billion are put towards mental health related expenditure in 2018 and 2019, which when we compare to the early 90s, it was at $3.2 billion. So we certainly have greater investment in mental health, and we certainly have greater uptake of services, which is a bit of a double-edged sword. On the one hand, it's great to see that more people are taking up services that exist, but on the other hand, we wish they didn't have to. To give you a bit of a closer snapshot as to what this looked like during the lockdown periods, particularly within Victoria and New South Wales. So the blue line in this graph shows Victoria, and the red line New South Wales. So you can see that at the peak of the Victorian lockdown, we were seeing extremely high numbers of uptake of Medicare subsidised services, and that this also sort of peaked again at the start of this year. In terms of our more crisis support services, so a service that many of you might be familiar with, Lifeline, which can provide sort of acute and crisis support. Lifeline actually, I don't have it on the slide, but I heard it on the news about a month ago. Lifeline received its highest number of calls ever in one day during the recent lockdown that we had. But in June, we had Lifeline receiving 81,000 calls over a 4-week period, which was a 19.1% increase from 2019. So over the past 2 years, we've had almost a 20% increase in how many calls Lifeline has received, particularly during that pandemic period, lockdown period, sorry. Kids Helpline, similarly, we've seen an increase, 27,800 and 7 contact attempts. 27,000 contact attempts by kids in 4 weeks during lockdown. That's huge. And again, 7.5% up from the same reporting period in 2019. And Beyond Blue receiving 23,000 calls and attempts for contact as well. Again, an 11% increase from 2019. So in terms of national expenditure on mental health related services, this in itself has increased from $396 per Australian in the 2014 to 15 reporting period to $420 per person in 2018 to 2019. In terms of global scale, the cumulative global impact of mental health disorders in terms of lost economic output is estimated to amount to $16 trillion over the next 20 years, which is an incredible amount. We know that mental health disorders are associated with underperformance at work and greater rates of unemployment as well as being related to increasing the risk of disability and mortality from chronic health conditions as well. So, models of intervention. Traditionally and typically, our ways of responding to those who are struggling with their mental health has been reactive. So what I mean by that is basically someone starts to struggle, they become unwell, and then the response is to provide them with some sort of treatment, which makes sense. The problem with that is that it doesn't address the rising trends that we're seeing. If we continue to do that, we're always on the back foot and we'll always be playing catch up. So we need to have more of a focus on interventions that are looking at not only prevention, but low intensity services and early access and early interventions. So this is where stepped care models come in to address the rising trend of mental health concerns rather than playing that sort of catch-up effect that we have been doing for some time now. We need this because our mental health system is struggling. It is significantly burdened at the moment, and I don't know if anyone here or watching online has tried to book in a consultation in the last year or so with a mental health professional, a psychologist, or a psychiatrist, but the waits are extensive. Add on top of that, if you need a bulk billed service or you're unable to afford to pay for a service and you're on wait lists of up to a year. To see psychiatrists, there are incredible wait lists. And often the people who are needing to see psychiatrists are the ones who are most needing that immediate support. You know, people will call services and say to us, you know, I need an appointment with a clinician. And if we sort of say, well, it's about a 1 month wait, they're like, well, I need it now. And fair enough. The longer we leave these problems as well, the worse they can potentially get. Not all of these concerns and issues, particularly when we're looking at significant, severe chronic mental health conditions, they don't just sort of get better naturally. We actually do need to provide some form of intervention. One of the moments that really stands out for me as I guess a little bit of a low point in my career, if I'm honest, is working at a psychiatric hospital where during the first COVID shutdown, we were running drug and alcohol outpatient services and we would run group therapy programs. And typically we could have as many people as rocked up on the day attending the program. It was no problem. But with the restrictions that came into place around the number of people that were allowed into the centre and social distancing, we had to really restrict how many people we could take. And for me, I think it's a moment that will kind of stay with me in my career, being given a list of all the people who want to come and attend the service that day, many of them known to us, so we know their history. Many of them extremely vulnerable because they've been cut off from so many mental health supports and health supports, and at real risk of relapse in terms of their addiction, and having to make a decision as to who can and can't come. It was horrible, and luckily it wasn't something that lasted very long because we were able to really push for alternative ways to be able to provide treatment to these people, but certainly not a position that I would ever want to find myself in again. But just to highlight the strain and the struggle that the mental health system has been under. So stepped care models of intervention in mental health. What do I mean by this? Essentially, stepped care models, it's an evidence-based system comprising of a hierarchy of interventions from least intensive to most intensive services and supports. So this came out of the National Mental Health Commission review of mental health programs and services. And it's very closely modelled on the system that we also have in the UK, which is the IAPT system, increasing access to psychological therapies. And the primary health networks within Australia have been tasked to essentially develop these stepped care models and implement them within their communities as well, based on the needs of their specific communities in a way that is quite flexible. There are three core elements to being able to effectively deliver stepped care models of interventions. Firstly, we identify that there are a range of needs that exist for individuals, but also for within a population or within a community, and that these needs can change over time. So we need a model that is particularly flexible to these changes, and we want to be able to provide interventions across the spectrum from health promotion to early access, early intervention, low intensity services, all the way up to our acute care services. We want to make sure, as the second principle, that a person is accessing care that meets their current needs and their preferences, because what we aim to do should always be person-centered and client-centered. And an important point about these stepped care models is that a person does not need to start at the first step and then progress up to where they need to be. They can enter the model at any point. So if I give you an example, imagine this is Jane, and Jane is 20 years old. She has no history of any mental health concerns or difficulties, but Jane's boyfriend has recently broken up with her. She is quite sad. She's crying in the evenings. She's reaching out to her friends, telling them that she's struggling. She hasn't handed in some of her uni assessments. She's handed them in late and lost some marks. But she's not having a particularly good time. Now, if I introduce you to Chris. Chris is a 50-year-old gentleman. He has a history of anxiety and what we would refer to as kind of OCD tendencies, never really severe enough to receive any treatment for, but certainly there. And when the COVID outbreak happens, Chris's world falls apart. He becomes extremely fearful of contamination from COVID. He is unable to go to work. He becomes housebound. He's unable to see his family, friends. He's unable to touch the walls in his house. He's unable to eat the food that the people from Coles deliver to his home. He becomes quite unwell. So both Chris and Jane might go and speak to their GP, which is often the first point of contact. And the GP is likely to refer them to some sort of mental health clinician, which is appropriate. A mental health clinician would be able to help both Jane and Chris. But it's possibly not the most effective course of action. It's certainly probably the most common one, but it might not be the most effective. Jane may, in fact, be able to benefit just as much from a lower intensity service, some sort of self-help or therapist-guided online intervention, say. And Chris may actually need a wider network support to help him get the assistance and the care that he needs at that point in time, so reducing the burden from one individual clinician. So if I can give you a bit of a snapshot as to what one option of a stepped care model for mental health interventions might look like. So we start from looking at ways we can service well populations. So the population as a whole, how we can keep them mentally healthy, essentially. We work up towards those groups that are more at risk. So not necessarily presenting with any early warning signs, but they may be vulnerable for a number of reasons. We then progress up to more mild and moderate mental health disorders, and then all the way up to our severe and acute mental health needs. And I will go into a little bit more as to what each of these may look like. But before I do that, I want to take a moment to tease apart two concepts which are often quite interlinked. So there is a difference between mental illness and mental health, right? We often kind of use the phrases interchangeably, but there's quite a difference. So an individual, if they have a mental illness, we're referring to someone who has a diagnosable mental health condition. And so this can exist on a spectrum, as we see on the horizontal axis, either low mental illness, and I guess all the way on the end of that would mean that they don't have any mental illness, all the way up to what we would consider quite a severe, significant mental illness. So this might be something like very severe schizophrenia, for example. Now, this is different to mental health. Mental health exists on a different continuum, and we look at this spectrum on the continuum of flourishing to languishing. Languishing is one of those terms that kind of came out a little bit more through the pandemic and probably what a lot of us were experiencing. That sense of low motivation, maybe some apathy. We don't feel like we really kind of care about things as much. We don't feel like we're living a life that's satisfying or in line with our values. It's not necessarily a mental health disorder or a mental illness, but it's what we refer to as languishing. On the other end, flourishing is that sense of us, if I can put it simply, kind of living our best life, living a life in line with our values. We're feeling satisfied, we're feeling fulfilled, we're engaging with the things and the people that help us feel good. And we're able to achieve and progress in terms of what makes us feel satisfied in our life. So, according to this, a person can have a very severe, significant mental illness and yet still have very high positive mental health. For example, the person who may have that severe diagnosed schizophrenia, if it's well managed, if they have a good care team, if they're on medication and it's appropriately prescribed, they can actually live a life where they're flourishing. So it's really important to disentangle both of these when we look at stepped care interventions and what's most appropriate for a person, and not just assume that because they have a severe mental health disorder that they need to be receiving a very intensive level of treatment. If it's under control, then they will actually benefit from a low intensity treatment or interventions that look at how they can focus more on positive mental health. So early intervention is crucial to changing the rising trends that we're experiencing with mental health. And as we saw before, the statistics around young people are really at the coalface of Australia's mental health crisis. 3 out of 4 people develop their first symptoms of a mental health disorder before the age of 25. And we know, research tells us that if we intervene early, we can successfully change the trajectories so that these individuals are not ending up with chronic complex mental health conditions. So stepped care models really help us focus on shifting our focus towards earlier interventions and more low intensity services. This means that people are less likely to need hospitalisation and more intensive interventions and strategies later on. If I give you a bit of a brief snapshot as to what interventions in each of these stages would look like. If we take the first stage of helping promote a well population, a healthy population, this might look like the primary health networks providing communities with health promotion campaigns, talking about how we can improve factors like lifestyle, diet, exercise, and also disseminating information about potential risks and early detection for mental health conditions. So some ways in which we've done a great job of this. Movember is going on at the moment. Any gentlemen out there rocking the mo? But Movember is fantastic for raising awareness for men's mental health and the stigma and shame that relates to men being able to share their vulnerabilities and their struggles. Are You OK Day, another really great initiative. The reason I like this one is because not that I've actually done any research on this, but I feel like just as an observer, I've been able to see change in the way that they have delivered this intervention. So if you remember a couple of years back, it was just ask the question, are you okay? Start the conversation. And what we realized is people are actually really scared to ask that question because they're worried someone will say, actually, I'm not okay. And then, what do I do with that? Right? So people weren't asking the question. So now, the last couple of years, The health promotion campaigns have been around, ask the question, are you okay? And if someone says, no, actually, I'm not, here's a list of 5 things that you can do and some services that you can refer them to. So it's really adapted over time, which I think is quite nice. And the other picture I have there is of a campaign that was developed by the New South Wales Responsible Gambling Service, looking at raising awareness for young people and the risks of online gambling, because we know that young people are particularly at risk for developing gambling disorders. On this note, I want to say a couple of words about stigma, because really what these health promotion campaigns are trying to do is to break down stigma so that we then can have people accessing interventions earlier or later whenever they need them. So the World Health Organization has defined stigma as a major cause of discrimination and exclusion. It affects people's self-esteem, it disrupts their family relationships, and limits their ability to socialize and obtain housing and jobs. So circling back to all of us here at this conference today working across sectors, stigma is not a mental health issue. It is a social justice and a human rights and a social change focus point for us. So reducing stigma from a mental health perspective is really key for people to be able to access and feel safe to access interventions earlier rather than later. We have made some good progress when it comes to stigma, but we know that there are particular communities within which we still have a lot of work to do. And so some of those, not all of them, but some of them are our culturally and linguistically diverse communities where there is still strong stigma within some of those communities. First Nations communities, LGBTQI communities, men's mental health, complex mental health disorders. So we've become a little bit better at normalizing anxiety, depression, maybe OCD, but you know, it's not the same if you go and say to someone, oh, you know, I had a panic attack yesterday, as opposed to I had a psychotic episode yesterday. You're going to experience a different level of stigma. So even within mental health, we're still playing catch-ups. And addiction is another area. And again, within addiction, we've become a little bit more aware and tolerant, for lack of a better way of putting it, of people who have perhaps alcohol and drug addictions. But when it comes to more behavioral addictions like gambling, sex, pornography, shopping, there's still kind of the mindset of, well, just stop, just don't do it. The alcohol, the drugs, I can see that there's something in your body that might be changing you, but the others, just don't do it. So we still have a long way to go when it comes to stigma. And one more thing I want to say about stigma is there's a way for us to do it really well, and there's a way that I've seen it done where it can invalidate the experiences of people with mental health disorders. And I'll give you a couple of examples. I was having a conversation with a doctor recently, and I was sort of saying something, you know, such and such happens within the context of trauma. And her response to me was, everyone has trauma. And I kind of paused, and I had this like uncomfortable feeling in my gut where I was like, I can see that she doesn't mean this comment with ill intention, but no, like not everyone has trauma, and that is invalidating to the people who do have trauma. And the reality is that some people do have very extreme, severe experiences of trauma or any mental health condition compared to other people. So in breaking down stigma, we can run the risk of invalidating the experiences of people who do really experience quite significant mental health concerns. Similar sorts of things you might see, like, you know, TikTok is great, the videos on social media for breaking down stigma, but again, it can be done in the way of, you know, oh, I had such and such experience and it was so traumatic. Sometimes I want to say to those people, like, was it traumatic? Are you experiencing flashbacks and nightmares and out-of-body experiences? Or are you just kind of saying that in a way that's now been accepted as language in society, but has some downfalls attached to it as well? So I don't know that I have an answer to that, but I want to throw it out there as something for us to consider. But back to stepped care models, that was a bit of a digression. So the next kind of stage that we look at are those people who might be at risk. And so intervention strategies that we're able to provide for this population in this group are things like self-help interventions and strategies, online or digital mental health services, used to be called bibliotherapy when we'd give out books for self-help. And these self-help strategies can either be purely self-directed or they can be what we call therapist-assisted. So an example of this is a service called This Way Up, which is an online website that is run out of St. Vincent's Hospital, I believe. And essentially it's a service that it's an online program that has a whole lot of courses that you can do. So this is really helpful for the person who calls up the clinic and says, I need an appointment with a clinician, and they say, sorry, it's going to be a 2-month wait. Rather than put that person on a wait list, why don't we do some form of assessment with them? And then if appropriate, say, well, it's like Jane, it's the first time you've ever experienced any sort of mental health disruption. It sounds like you're struggling, and maybe you could benefit from a online program such as this, a 5-week self-help depression course. Right? And that might be all that Jane needs. So This Way Up is an online program where you can either sort of enroll in courses on your own, or as a clinician, I can prescribe a course to a patient. So if I have that patient who comes to my clinic and we say, sorry, there's a wait, I can do an assessment and I can say, here's a course to get you started. I will prescribe it to you, which means I can oversee your progress. I can track the change. I can see your responses on the online questionnaires. Complete this for the next month or however long it takes, and then let's do another assessment and see where you're at and what you need. Because one of the key points in stepped care is that we need to keep reassessing to see what a person needs at any point in time, and not just assume, but actually reassess. That might be all that person needs, and then fantastic, they're good to go. Another example of targeting at-risk groups is a program called Mood Active. So these are actually exercise groups and exercise programs, but they're targeted specifically towards people who might be at risk for mental health difficulties and a mental health illness. These are generally low cost or freely available within the community. But one of the things I like about this, thinking about the rates of prescription medication that we talked about before, is that research shows us that for a significant number of people, antidepressant medication is as effective as exercise. It's just that it's much harder to get people to do the exercise. And fair enough if someone is quite depressed. But what a great way to be safeguarding ourselves and our mental health. We then move on to those who are experiencing more mild mental illnesses, and this is where we start to have our more low intensity services. So these might be things like peer support groups or therapy groups or therapist assisted online interventions. And so MindSpot is, I believe, a federally funded service. It's run out of Macquarie University in Sydney. Again, a range of online programs that people can access. However, the difference is that they also get access to a clinician, either for regular or weekly phone calls or via email, whatever they prefer. So the course is not so much a self-help as what we would call therapist assisted. Again, a lower intensity service that if a person is not experiencing a significant mental health disorder, could very well be very appropriate for their needs. And another option similar that would fall into this category is something like a smart recovery group or program, which is addiction-specific therapy groups. We then move to our more moderate mental illnesses, and this is sort of the intervention services that people would typically think of when we think of getting mental health care, seeing a psychologist, a mental health social worker, or someone who works within the mental health space, as well as engaging with GPs regularly. And then finally, we move up to our more severe and acute mental illnesses, where we're looking at providing high intensity services. This might be engaging with a psychiatrist. It might involve inpatient care. It might involve long-term rehabilitation. And also our crisis services fall under this category as well. So how am I going for time? All right. So essentially highlighting the different stages of care that, you know, for many of us, we don't necessarily think of as options. And unfortunately, the referral pathways towards them are not particularly strong because they are newer ways of working within these stepped care models, but definitely going to reduce the burden on the system, but also be more cost effective, not just for us in terms of the systems that we're implementing, but also for the consumers as well. Just to give you some statistics from the service that I mentioned, MindSpot. So this is the one where you can access programs that are therapist assisted, either over the phone or via email. In terms of what COVID looked like for them, so in the early months of COVID last year, so March to June, they had an 89% increase in website visits. They had a 90% increase in telephone calls and a 16% increase in mental health assessments that were completed compared to 2019. So a really significant uptake in services, which, as I said before, fantastic that people are using the services, not so great that they need them. As for This Way Up, which has the self-directed mental health services, they had 2,806 registrants in the 3 months prior to the pandemic, and then 21,800 registrants in the first 3 months of the COVID pandemic. So they went from almost 3,000 to almost 22,000. Massive, massive increase. So there's economic benefits to stepped care models. They aim to offer lower intensity treatments as early interventions and involve minimal financial and time costs as well to the consumer, to clinicians, and to services. Now, in amongst stepped care approaches to providing mental health interventions, we also really need to focus on collaborative care across sectors. So similar to the points that I was making earlier, you know, within mental health, we cannot just be servicing mental health needs alone. Much of the work that I've done has been in disability and addictions, and the story that I hear time and time again in disability, for example, a client with a disability goes to a disability service, and the disability service says to them, "Oh, you have a mental health condition. You need to go to a mental health service." And so that person goes to the mental health service and they go, "Oh, you have a disability. You need to go to a disability service." And the person gets stuck and lost in the cracks, unable to access treatment. So we really need to be focusing, you know, in addition to these stepped phases of mental health interventions, as to how we can collaborate across services and sectors. As we said, we need to be addressing mental health not in isolation, but in amongst all these other issues that we're facing, which is a big reason as to why I'm so pleased to be here at this conference, in amongst so many bright minds, wise minds, people with lived experience, people with knowledge who, you know, we can hopefully come together and solve some of these issues and push for issues, push for change. So on a final note, and then I'll take some questions, what can we do? Because it is my hope that when we go to these talks, we do actually walk away from them thinking about even one small step that each of us can take, one small change that each of us can make. So what can we do? We can start the conversations and we can normalize the conversations around mental health, keeping in mind appropriate ways to manage stigma. We can speak up when we see that stigma is being perpetuated. We can ask the difficult questions. We can ask the questions of, "Are you okay?" Looking into and researching how to answer if the answer is no. We can get involved in our workplace in looking at mental health strategies. We can ask the schools of our children, you know, what are the schools teaching kids around good mental health? How are they how are they targeting prevention? We can bring mental health into our conversations across sectors. Hopefully, in the various sectors that you work in, you can start to bring mental health into your conversations, just as I need to be bringing in so many other conversations into the discussions I have with colleagues and peers, not just about mental health, but all the other inequalities that we face. And finally, to take a line from Con's presentation this morning, come back to our values and be human. Connect with people, be person-centered, engage in the shared struggle of what it means to be human. Not everyone needs to see the psychologist. Sometimes people just need an ear on the other end of a phone. Sometimes people just need a friend to talk to, or like the gentleman at the taxi rank that I saw, sometimes it's just a stranger on the street who's willing to listen. So let's continue to have the conversations, and let's go out there and keep pushing for change. Thank you. So if there are any questions, either from the audience here or online, I'd be willing to do my best to answer them. Yeah.
Thanks so much. I'm just curious to know if the online services that you mentioned, whether there are financial barriers and other services that they provide. Just knowing through personal experience and general knowledge that financial instability does often go hand in hand with times of crisis.
Yeah, absolutely. Some of the services I've mentioned are no cost. I know Mood Active, that exercise group off the top of my mind, it was no cost if you were in a financially difficult position. And for those who were able to pay, it was very low. It was like $5 or $10 max. Some of the other services, so This Way Up, which if I prescribe a client a online course, it's free. And I don't need to pay to sign up to be a registered clinician with them. If clients are accessing it on their own accord, not under the care of a clinician, there is a cost. And off the top of my head, that cost is around $40. Yeah, so it varies depending on the service. Yeah.
Thank you very much, Anastasia, for the it was generally enlightening, insightful. So actually, that slide we showed about TikTok, we talked about how not all of the, those who bloggers say, are expressing their traumas. They're not as what they actually describe. Someone when I say I mentioned PTSD or traumas, they don't have those flashbacks, but they are a little bit inconvenient. But that doesn't mean they have that specific illness. But I wanted to mention something else actually on this topic of social media. I wanted to see your insight on it, or maybe what have you noticed during the past 2 years, particularly from social media addiction and how this lockdown lifestyle has increased so much activity on the social media that caused actual depression or caused some problems. The social media addiction by itself. And I was wondering if you could share some insights on that.
Good question about how COVID and the lockdowns have changed our social media use and potential social media addiction. I think generally we've seen a spike in most mental health disorders across the board. In terms of addictions, social media or internet addiction isn't necessarily yet recognized as a diagnosable mental health disorder, like something like shopping or gambling or sex, etc., might be in terms of behavioral addictions. So that means that it is a little bit more difficult to measure and track. So I don't know that I can provide exact statistics or insights as to how it's changed, but I know thinking about young people, certainly we did see that there was a real difficulty for a number of children and teens making the transition back to face-to-face learning and schools. I'm not sure what the situation is here in Victoria, but a few weeks back we made the transition in New South Wales back to face-to-face learning, and children who had never had a problem attending school before, no issues attending, great engagement, no behavioural problems at school, all of a sudden school refusal, wouldn't go back. So in terms of the effects of sort of transitioning to online and then back to face-to-face, I don't know what it is exactly, but we are certainly seeing something there with our young people. No questions online. No questions here. Yes.
Talking about stigma, and I 12 years of working as a case manager and social settings, and I come from a refugee background, and we have witnessed traumatic events, and I'd like to talk about it necessarily, but when we talk about stigma, like we all have, like you said, been depressed at some point, and it always comes to mind, it's like how can you help someone if you actually, if you can't help yourself, and that's stigma in itself, in a way.
Yeah, totally. So if you're someone who's experienced, mental health difficulties yourself, how can you help other people? I mean, the drug and alcohol sector has done this really well, where we have drug and alcohol clinicians with lived experience, and that for many services is seen as an integral part of the staff, that we need people who are running the therapy groups and providing the clinical work who have lived experience themselves, because, I'll often say to clients, like, I know the psychology stuff, but you're the expert in you. Only you at the end of the day know what's going to work best for you and what is working well for you and what's not. And so we got to come together with our knowledge, mine with psychology, yours with yourself, to find the best solution. And I think if people are able to bring some sort of lived experience to that conversation, we need to be mindful that it doesn't colour how we're working with that person, but if we're able to get appropriate supervision around that, then I think it is a real asset, an absolute real asset. Yeah, because you're bringing a new lot of insights that someone else won't be able to. Yes. So how would you combat that, say, in communities where maybe there's a higher rate of that? Yeah, brilliant question. So essentially overcoming barriers, particularly around technology. We saw this with COVID, where everyone was like, yay, telehealth, but some of our older populations, they don't do Zoom. They don't have the phone with the camera, and nor do they want to try and navigate Zoom. So absolutely, we do have similar options that we would refer to as bibliotherapy, which is essentially like books. But again, we're looking at if someone has low literacy or unable to engage in books, how do we come across that? So it's an imperfect system, I guess, is the answer. There is work that is being done to adapt the courses so that they are more appropriate for particular cultures, and focus on different needs, but we still have a lot of work to do. Yeah. Yes. I'm not getting the benefit of what position, and I would be get stuck in what a number to say to the client. So I'm just trying to find out what you're expecting. Yeah. They're not going to be in a position of, oh, we just talk, and I'm not sure what to say. Yeah. Yeah, it's interesting. Sometimes we come across clients and people who put a lot of emphasis on us to create change for them, and that's a really tough place to be in, because we can't make the change. We can help facilitate and guide it, but at the end of the day, us as clinicians, we can't do the changing for someone, and So for those people, one of the strategies that I've learned along the way is to sort of gently kind of put that back and be like, well, what do you think we need to do? What do you think you need? Genuinely, not as it meant to be as a condescending comment whatsoever, but you know you best. So if you're telling me this isn't working, if you're telling me you're not benefiting, because right now in that moment, that might be how that person feels. What do you think we need? Like, guide me, because I have this bit of knowledge and you have this bit of knowledge, and let's come together, and I'm willing to learn from you. Yeah, that's the best I've got. Yes.
Websites. How can you implement this in the current situation? How can psychologists and mental health workers can they apply this? This is a very good model to study their approach. Also, those prescription for those courses utilizes that wasted time and it would stop repelling those needs.
Yeah. So how do we better utilize the earlier steps? Implementing them, absolutely. I think this very much needs to be a shift in the system. So really working to educate the first points of contact. Often it's GPs, educating them around there are so many other options that are available. And understandably, GPs need to know so much. So sometimes us as clinicians, we will send out like a one-page summary of like, here's a bunch of really useful resources that you can recommend to clients, or that we can set them up with, you know, the GP and myself working collaboratively, we can set them up with this course while they wait for an initial appointment or to have ongoing sessions if they need it after the course. But I think it really needs to come from us on a systems level, being able to better share the knowledge that these services are out there. Brilliant. I think we are good for time. Brilliant. Thank you so much, everyone.